Hi, good evening, everybody, or good afternoon for those in the States. I am pleased to be doing a live on a Monday night. I'm going to be joined by Dr. Gad Lavy, who is the medical director and founder of New England Fertility Institute. And we are going to talk all about LGBTQ plus same-sex family building to mark Gay Pride Month, and he is kindly going to be answering anybody's question around family building for same-sex couple parents to be. So let's welcome him in now, and we'll take your questions. Feel free to ask anything you like, whenever you like, and we'll get to it. Good evening or good afternoon, Dr. Levy.
Good evening, good to be here.
Thank you so much for joining me tonight. I've just given a brief introduction to the topic for tonight, but for those who don't know you, please could you start by giving an introduction to yourself and also New England Fertility Institute?
My pleasure. And thank you, Louise, for inviting me to speak today. And thank you all of you for joining us. So my name is Dr. Lavy, Gad. I'm a fertility specialist. I have my own clinic. The clinic is located in Connecticut. So we're about 1 hour north of New York City. I've been in the fertility field for more years than I'm willing to admit, but for many years. And our clinic is basically focused on the entire range of fertility treatments, diagnosis, but basically with more emphasis on what we call third-party reproduction, which is egg donation and surrogacy. That's something that I always was passionate about. It basically allows us to work with clients that are not just local. We have clients from around the country and actually international. And I would say that more than 50%, probably about 60 to 70% of our clients are same-sex men who are basically looking to have a baby, and their option, or the options we offer them, is basically using an egg donor and a surrogate.
Mm-hmm. So you must have, as you mentioned, a lot of people traveling abroad to do that through New England Fertility Institute because you have such expertise in it.
Well, yes. However, things are changing, and, especially with COVID impacting pretty much everything, every aspect of our lives. So with COVID, actually, we're learned to do things differently. And in many cases, actually, the couples that are, for example, same-sex couples from Europe don't have to travel to the US. We can arrange for them to ship the sperm to us, and we can create embryos with an egg donor, and we can use a surrogate. So we are able to actually limit the number of trips that people have to make to a minimum.
That's great. So please can we start by talking, obviously we're marking Gay Pride this month. So we're going to talk about same-sex couples, female and male, and of course, individuals who may be doing it on their own as well. So for same-sex female couples, what is the starting point? What is the process? And what do women need to consider at the beginning and throughout?
So for women, the process is a little bit different. I would say that, in most cases, one partner will carry the pregnancy. So that so they don't really need to use a third person, a surrogate. So it's for them basically just having a conversation and deciding who will carry. And then deciding, essentially, if they're going to use a sperm donor, who that sperm donor will be. So I'd say that the typical case is a couple comes in, they have a plan, we talk about it, we help them find a sperm donor, and then we set up their treatment. Now, in most cases, of course, the person who actually will have the treatment, the insemination, will have a fairly simple evaluation just to make sure that everything's working. Check the hormones, check the uterus, check the fallopian tubes. And then, of course, we will assist them in finding a sperm donor. We usually work with sperm banks. sperm banks actually follow very strict rules as far as how they screen their donors, what kind of testing that they do. The samples are frozen and they're kept frozen for, in the US, for 6 months. Donors are retested before they're released. And then we receive the frozen sample. The woman basically prepares for her insemination, either with her own cycle, what we call a natural cycle, or with a little bit of fertility drugs. So that would be sort of the fairly straightforward, most common scenario, I would say.
Mm-hmm. And how do the women decide between, or what would you suggest in terms of whether they start with IUI versus IVF, for example?
So then that goes to basically the evaluation. So we go over the history, we go over the different testing. It has to do with their age, of course. There has to do with their history, if they have any issues that basically preclude using IUI. For example, if the tubes are blocked.
Mm-hmm.
Some couples actually want to know the gender of the baby, so they do IVF for that reason. So I would say that in most cases, again, in a typical couple, we usually start with IUI because it's easier and it's less expensive, and it actually works quite well. And what I think for most people, I think probably the most important is that we sit down, we do the evaluation, and we go over the results, and then we say, okay, now let's come up with a plan. Let's come up with a plan, and the plan could be, let's try IUI for 2 or 3 months, because that's usually a number of times it takes for it to work. Okay. And if it doesn't work, then we do IVF. There are times where you do IVF right off the bat, and for example, if there's a problem with the fallopian tubes, if the fallopian tubes are blocked, then you have no other choice. Sometimes if the woman is a little bit older, IVF has actually better success. And of course, there are couples that do what we call reciprocal IVF, when one partner gives the eggs and the other one carries. So of course, to do that, you need to do IVF.
And who is that suitable for? It sounds like a lot of people are opting for that at the moment, because sometimes it's known, isn't it, as well as shared motherhood, so that one person can carry and the other person uses their eggs.
Well, it really has to do with the couple and how they feel. I think it's wonderful. I think it's a beautiful thing to do. Mm. Of course, sometimes you can tell who is a candidate to give the eggs, who's a better candidate to give the eggs, and who's a better candidate to carry. So, if, for example, if one partner is 35 and the other is 45, clearly the 35-year-old is a better candidate to give her eggs.
Yeah.
But the 45-year-old can probably carry with no problems. So, of course, there's those restrictions, those limitations.
Mm-hmm. Yeah, absolutely. And so does that, and where does that sit in terms of success rates for lesbian couples?
Well, and the success really has to do with the individual's history and the workup. One of the things that we of course is very different between men and women is that women have a fairly narrow, what we call, reproductive window. So once a woman gets into her late 30s, early 40s, her chances of becoming pregnant or having a successful pregnancy goes down fairly quickly. Mm-hmm. Not so in men, right? Men continue to produce sperm essentially throughout their lifetime. Women basically have all their eggs when they're born. So one of the first things that we test for any woman who wants to have a baby is what we call the ovarian reserve. And that's sort of an indication of how many eggs they have or how many eggs they have left. Because as the egg reserve dwindles, basically the number of the eggs that remain are not of the best quality. So that allows us to have a pretty good idea of what the outlook is, what are the chances, and also help direct the treatment as well.
Mm-hmm. And I guess in terms of donor sperm, you would expect, wouldn't you, if it's from a bank, that it's going to be good quality sperm, given the banks do so many checks, don't they? And they don't accept everyone into the program at all.
Yes, so we work with basically only with sperm banks that we know and that we have experience with. And those actually have very strict criteria on their donors, not just their medical history and then the psychological evaluation that they do, but of course the sperm.
Mm-hmm.
sperm
Yeah.
count. So, you asked about the success. So essentially, in the ideal situation, if we have, a woman who's young and healthy and does an IUI cycle, we expect probably about 20 to 30% success for each cycle.
Okay.
If we do an IVF cycle for that same person, we probably expect about 50 or 60% success
Wow.
for one cycle.
Very good, isn't it?
So yeah, so IVF is very tempting sometimes just because it has a success, but on the other hand, it's more involved and more expensive,
Mm-hmm.
and
Yeah.
it has to sit right with the couple.
Mm-hmm. I had IVF with donor sperm because my husband's infertile. So I guess we were gifted with success after the first round failed, but we were lucky in that there didn't seem to be an issue on my side. So we had the sperm was checked, etc. So we were hopeful that at some point there might be a success there, and I guess that might be similar to same-sex female couples where there isn't a known male infertility issue or a known female issue.
Exactly. So the idea is, and it's usually true in most cases, because again, if you work with a reputable sperm bank, you assume that the sperm is fine, that you don't have to worry about that. So
I had a question from a same-sex couple the other day, actually, who were looking for donor sperm, and they were questioning whether the donor that they wanted to pick, whether they should go for it because that donor had not had any reported pregnancies before. Would you be skeptical of someone using a donor if they haven't had any pregnancies yet?
not really. I think that for most part, I think the sperm banks have other ways to assess the sperm quality and the sperm function. So I think for most people, actually insisting on what we call a proven donor, a donor that actually has a history of pregnancies, I think you're just basically limiting your choices.
Mm-hmm.
And I don't think that there's any evidence, at least in my experience, that the donors that have those proven donors have a better track record.
And what about, because I obviously using donor sperm myself, I know I'm not in a same-sex couple, but it's something that people need to consider when picking a donor and a sperm donor. The HPV virus, is that something that people need to consider when they're selecting a donor?
Well, again, it should be. I mean, those things usually are in the history. I know nowadays more and more women actually get the HPV vaccine. But sometimes it's not in the history, and sometimes you're not vaccinated. I think in those cases, the risk of actually contracting HPV through an insemination I think it's very, very, very low.
Mm-hmm.
I mean, I wouldn't. It's not.
Yeah, absolutely. And success rates for donor eggs, fresh versus frozen, what do those look like?
Well, so the story with frozen eggs, I think there's a lot of, I would say, misconception. Just forgive the pun, because there's a history of basically where we in the past using frozen eggs was not as effective, not as successful. So once that the word is out there, it's very difficult to change people's opinions. But what has happened actually in the last, I'd say, decade, maybe 5 or 6 years, that technology that we use to freeze eggs has improved dramatically. And it allows us basically to get the same results with frozen eggs as we get with fresh eggs. So I think, again, and people, I mean, the word is out there, and sometimes it's difficult to get people to change their opinion. But we have excellent results with frozen eggs. As the idea was once the technology for egg freezing reached that stage that you can actually have egg banks, the same as you have sperm banks. So it opens up basically more options for people, both as far as and as far as the cost.
Yeah, and I guess that's a preconception that people may have around frozen embryos versus fresh embryo transfers as well in terms of success rates too. Is that something you get asked a lot?
Well, I can tell you that, we don't anymore do fresh embryo transfers.
Ah,
So all the embryo transfer that we do are with frozen embryos. And the reason we do that is because we get better results with frozen embryos than we get with fresh embryos.
is that because the female has the woman has a chance to recover from the cycle and the retrieval prior to having the transfer?
So yeah, so if it's the same person, if somebody goes through IVF and creates their own embryos, then of course exactly what you said. When you're going through your IVF cycle and you take all the fertility drugs, the purpose there is to produce as many good eggs as you can. And what happens when you do that, your hormone levels go up, and those high hormone levels are not necessarily conducive to pregnancy.
Mm-hmm.
In other words, they can affect the uterus in ways that make it less receptive to an embryo. So the idea is to basically do the IVF process in two parts. The first part where you focus on creating the embryos. So you don't compromise, you just give the medications and you basically get the eggs, make the embryos, and at the end of that process, we freeze the embryos. And then the second part, the embryo transfer, you can focus on the uterus and make sure the conditions are optimal, not having to worry. And so, for example, many of the embryo transfers that we do with frozen embryos are in the woman's natural cycle, where we use very little medications and allows us to take advantage of the fact that the body actually prepares the uterus naturally for pregnancy, and we just have to find the right time in the month, in the cycle, to put that embryo in.
Mm-hmm. It's another reason that you wait to do frozen transfers because a lot of people have embryo PGT testing now.
So exactly. So that's the other reason, of course, that and again, we do genetic testing of and pretty much in all cases. Uh, Allows us again to identify those embryos that have the best chance of success. Now, if you do the genetic testing, you basically remove a few cells from each one of the embryos and send the cells to be evaluated, to be tested. And that takes a few days. So basically, you need to freeze the embryos, wait for the results, and then wait for the next cycle to put the embryos in. But yeah, so that's one reason. But I would say that even in cases where we don't do the genetic testing, I still prefer to freeze the embryos and not transfer on the same cycle.
That's really interesting. Thank you for sharing that with us. And I've heard something very exciting in terms of some developments that have come about. Can you tell us a bit more about platelet-rich plasma, which is referred to as PRP? Is that correct?
PRP, yes. So, this is actually, the reason I like my field, I love to do what I do, is because it's constantly changes. And what is today is going to be very different in 6 months.
Mm-hmm.
Uh, so one of the new areas of interest, of our interest, is using PRP in two ways. One is to improve ovarian function, and the other is to improve uterine function. And just in one paragraph, the PRP actually stands for platelet-rich plasma. And basically, the platelets, one of the cells in the blood, are known to actually contain some growth factors. And growth factors actually are enhance healing and growth. So this is something, it's not new, and it's actually been in use for a good number of years now in cosmetics, for example.
Oh, okay.
It's used for to improve hair growth. It's used for wrinkles. So it's been used in cosmetics. It's been used in actually in orthopedics for degenerative
Wow.
spine disease, disc problems. So and there's really not very much in our this is in a way similar to using stem cells because it's the same factors that stem cells have. So we're actually embarked on this research project where we basically take those platelets and use them either in the ovary to improve egg production or in the uterus for women who don't have a good uterine lining, where the uterus doesn't develop properly. And the thing about it, it's of course it's new and it doesn't really have much of a track record, and we're trying to get some data now. But the process is very simple and it's very safe because it's basically using your own blood components. So you come in, you grow your bloods, just spin it down and isolate those growth factors and inject them back into you. So it's very exciting. It's still brand new and we don't really have a lot of experience with it, but I believe that it's actually going to, it has promise.
So which kind of patients have you suggested or have you used this procedure on?
Well, so as I said earlier, women have a sort of what we call a limited reproductive window. So one of the biggest issues that we find in individuals and couples is that basically the woman comes in and she's a little older and we basically find that her egg production, egg quality is not good. And so if you have a 41, 42-year-old, we find that ovarian function isn't good. Their chances of having a successful outcome is very low. And unfortunately, we don't really have anything to offer other than using different medication to stimulate ovarian function.
Mm-hmm. And
for those people, actually, what we recommend mostly is egg donation. I mean, you have your uterus is functional, there's sperm, but the eggs are not good, so you'll use an egg donor. So, and of course, an egg donor is a big step to take for many people in many ways.
Mm-hmm.
So this is one option that would allow you, hopefully, possibly, to still use your own eggs. Same true for uterus. There are some cases where the uterus is damaged as a result of surgery or infection. And basically, even though you have eggs and you have embryos, the uterus environment doesn't allow the pregnancy to take hold. Again, we don't really have much to offer to these women. And basically, at the end, if nothing works, we recommend surrogacy. Again, a huge step to take.
Mm-hmm.
So the PRP actually using it to try to enhance uterine function is a step before surrogacy. And, hopefully if we can get that to work, it would allow women to carry themselves.
So thinking about or talking a bit about surrogacy and family building for same-sex men,
yes.
What's the process there? How do men start this? What's involved in it in terms of checking their fertile health and their sperm and fresh versus frozen for the sperm, everything really?
So there's a few steps, and I always recommend that, the first step should be to check their sperm. Just to do a semen analysis and see what the sperm looks like. And with that information, and as we're just talking, it's the same as we talk about the same-sex women couple. They need to decide who is going to be the biological father. I'd say most of the time that actually couples come in and they want to have one child. Sometimes not, but of course, in order to do that, you want to make sure that the sperm is okay. So usually that's the first step, step in that journey of surrogacy. Typically, we will take the sperm, make sure that it's okay, and then we freeze it. Again, we use freezing for sperm as well, with very good results. That allows us to make sure we have the sperm, allows us to do all the regulatory testing that is required for surrogacy, and then allows them to move on and focus on the rest of the process. And then, of course, to have the baby, you need the sperm, you need the eggs, and you need the uterus. So they will need to find an egg donor, and we will help them with that. The egg donor is, again, we can talk egg donation for a while, but basically making sure that we find a donor that is healthy and it has good eggs, and a donor that meets their requirements, whatever requirements they have. So we have the sperm and we have the egg donor, and then immediately we start working on creating embryos. So the donor goes on her fertility drugs, usually produces about 15 or 20 eggs. The eggs are harvested, they're fertilized. If they're creating embryos for both partners, we split the eggs and create basically two sets of embryos. And then those embryos get basically tested, genetically tested, and frozen. So that's the first step in the process.
So like we were talking about with the reciprocal IVF for two females, it's quite a nice way for men to build a family in that, as you said, you can split the sperm down the middle. So if they wanted to have a second child, for example, they could use the other partner's sperm.
And that's, again, is something that you need to spend time and think about and be comfortable. So, for example, what I often, because sometimes, gay men come in and say, we want to have children only for one partner. So I think it's always a good idea to think ahead. And, because, like I said, we can freeze eggs, we don't have to fertilize the eggs. We can make embryos for one partner, but we can actually keep a few eggs unfertilized. Mm-hmm. Freeze them, and then they have the option, if the other partner at some point down the road decides that they want to have their own biological children, we can go back and use those frozen eggs.
Fascinating. So many options these days, aren't there?
I think, yes. I think it's, it's a good thing, but it's also makes it a little difficult to decide what to do.
So I've got some friends, same-sex male friends, who are going to America at the moment to do this process, and they have already made up their embryos, and they're just waiting for a surrogate now. So what's for people who are coming abroad and for people in the same-sex men in the US, what's the process with the surrogate side after the embryos have been made?
So in the US, in order to do this process, you need to have a clinic, a fertility clinic, and you need to have a surrogacy agency. And basically the role of the agency is to find you the surrogate, and then take care of all the legal arrangements and all the payments. The clinic, of course, does all the medical parts and also is involved in the screening, the medical screening, the psychological screening of the egg donor as well as the surrogate. So it's a really important thing to realize that you need these two entities. And of course, it's very important that the clinic and the surrogacy agency work well together. And so it's usually you get, if you go to the clinic first, they usually would recommend an agency that they know and they work with, and vice versa.
Mm-hmm. And what's the normal wait time for a surrogate?
I would say, an average, probably somewhere between 4 and 6 months. And of course, it changes, and COVID, I think, has changed that as well, because it looks like maybe the demand has gone up a little bit, and the number of women actually who apply for surrogacy has gone down.
Right.
So
what do you think it is?
Yes, I don't know, but I think one day we're going to study all these things that COVID did, and I think that's one of them. That I think people actually have had more time to think about their lives and their priorities, and are finally deciding to move forward and start a family. Mm-hmm. I think we see that.
I do think surrogacy is an amazing thing. If I had my time again and was in a position to be able to, I'd love to be a surrogate.
I have to tell you, I've been working with surrogates for many years, and I still am amazed when I meet, you sit face to face with a surrogate. They're definitely a different breed of people. Mm-hmm. They're very giving. They're very special women.
Mm. Absolutely. And what about gay men who may be HIV positive?
So, so again, sort of probably a misconception out there that, you know, if you're HIV positive, that there's no way that you can have children, especially with a surrogate. But that's actually not true. And, you know, we work with actually quite a few HIV positive men. And there is a process by which you can actually process, or we call it wash the sperm, and essentially make sure that the sperm doesn't carry the virus.
Wow.
Means that you can then create embryos with that sperm, and you can reassure the surrogate that she's not at any risk.
Mm-hmm.
So we work with in the U.S. They're actually probably the most known is the Bedford Institute in Massachusetts.
Right.
The founder, Dr. Kiesling, is actually one of the pioneers on HIV and sperm. And we work with her, we collaborate with her, and the men go there, they give the sample, they basically do the processing, and we can use that sperm then safely for surrogacy.
Wow, that's incredible. And if anyone has any questions for Dr. Lavy this evening or today, sorry, please do feel free to ask. We've covered a lot, and I know there's so much more that we could talk about it. I guess also same-sex people who might be LGBTQ plus wanting to have children who aren't in a relationship as well. What's the situation there? Is it pretty straightforward in terms of looking for a donor? Or a surrogate?
It's really no different. I mean, you know, we have, of course, men, women, singles that decide that they basically decide to have children without a partner. And it's perfectly fine. And the process really is exactly the same process. Maybe simpler, but the same process.
Mm-hmm. Absolutely. Well, thank you so much for all of your insightful sharing so many insightful things this evening. It's been fantastic, and it's been a pleasure speaking to you.
Yeah, thank you for having me. And, you know, of course, each one of those topics you can spend hours and hours reviewing in details, but I just wanted to basically maybe give like the flavor of what it's like. Yeah. And mostly to, you know, to make people understand that all these things are possible and doable.
Mm-hmm.
It's intimidating from the outside before you actually, you know, understand exactly how it works. But once you actually dig into it and you see the steps, it's very doable, and it's not as difficult as it sounds.
No, I think, sorry, I know we're finishing off, but I think that one of the things I've heard quite a lot from same-sex couples who I've spoken to and done podcasts and things with is that parents, when they come out, parents may have misconceptions or preconceptions that because they're gay, that they're not going to be able to have a family in the future, which is so not true anymore, is it? There are so many ways to create a family, which I think is fantastic, especially having donor conceived children myself. It's a wonderful gift people can give.
Yeah, no, I think, you know, and again, I already said that I love what I do, but it's the thing is that if you're willing to take advantage of all the technology that's out there, then pretty much anyone can have a child.
Mm-hmm.
So whether you're single or you're in a relationship or you're gay, or essentially there's a solution for each one of those people.
Absolutely. Well, thank you again. And if anyone wants to get in touch with Dr. Lavy, then please, you can come through Fertility Help Hub, or you can direct message through to New England Fertility Institute. So yeah, thank you everyone for joining.
Thank you for being here, and thank you, Louise, for inviting me.
You're welcome. Bye-bye.
Bye-bye.
Bye.